Hey guys, welcome to podcast part 11. So we're just going to jump right into it with some OBGYN topics since I feel we've been negating the good old OB. Let's start off with different types of uterine contractions. So there's two categories of contractions. There's pregnancy and labor contractions, okay? So during pregnancy you have all these false alarm contractions. They're called Alvarez waves, Braxton Hicks, or pre-labor, and their name depends on kind of when they occur during pregnancy. So in the second trimester, you're more likely to have Alvarez waves, which are these kind of low intensity, high frequency contractions that don't mean anything. And the third trimester, Braxton Hicks, that's when that happens. And the frequency for these is usually a couple per hour maximum, and the duration is usually less than 1 minute. The important thing here is these kind of ramp down over time instead of ramping up as in with real labor. And pre-labor contractions are those ones that are pretty irregular, but they happen more frequently, about every 10 minutes. And what happens here is that they're predicting contractions for stage 1 of labor. So they're kind of at the frequency of stage 1, but they're irregular. They happen about 3 days before labor, so they're essentially practice run contractions. All right, so stage 1 and stage 2 have even more frequent contractions. The differentiating factor is these kind of ramp up with time, so they ramp up frequency, they ramp up strength, and also they're about 1 every 10 minutes at the longest, and then 1 every 2 to 3 minutes at their most frequent. And the measurement for these contractions is called Montevideo units. An adequate one during labor is about 200. So you know that if you have an arrested labor, it's going to be less than 200, okay? So let's go through the stages of labor. These are important to understand because they're often tested. There's really 4 stages of labor, but I think the first 3 are the ones that are really tested. The first stage has 2 subparts, latent phase and active phase. So really when we're in the first stage of labor, we define our stages kind of by cervical dilation. And the cervix from 0 centimeters to 6 centimeters is in the latent phase. Contractions here are mild and infrequent. They have in nulliparous versus multiparous women, this stage lasts different amounts of time. So you can remember nulliparous is 20 hours, multiparous is 14. This stage is usually associated with a bloody show, rupture of membranes. The bloody show is really from a mucus plug that's coming loose, so you have a little bit of blood coming from that, right, in the cervix. And then the active phase is from 6 to 10 centimeters. You have increasing rates of contractions. This happens for about 4 to 6 hours in nulliparous and 2 to 3 hours in multiparous women. And the progression here is about 1 centimeter every hour. And if you progress slower than that, you could be in an arrest situation or a situation where you'd have to do something like give oxytocin, prepare for cesarean if necessary in some cases, okay? So the second stage of labor is the stage where the baby actually comes out. This is a stage where the cervix is fully dilated, 10 centimeters plus. This stage doesn't last too long. It's about 2 hours for nulliparous and then 1 hour for multiparous. You add an hour if they have epidurals, so just remember that. Epidural adds an hour to this stage. And really the baby's going to be crowning at this point. You should have be helping the mother out, with getting her comfortable, episiotomy if necessary, and get ready for childbirth, because after that we're in the third stage. The baby is out. This stage is actually the shortest. This is when the placenta gets delivered. This happens within 30 minutes. After the placenta gets delivered, you usually have a gush of blood. The cord is kind of lengthening out before the placenta comes, so it gives you a little bit of a warning. And then the fundus rebounds to its original shape. The fourth stage, which isn't really mentioned in all too many places, is the postpartum period, where you just kind of monitor for hemorrhage or preeclampsia, because remember, preeclampsia doesn't just happen before birth, it can also happen after. So watch out for a preeclampsia question after, like postpartum, right? Okay. So different types of pregnancy arrest, because those are the questions that we're going to get. What happens when pregnancy is going slower than expected, or the progression is not as good? What do you do? Okay, so first stage of labor, we have 3 different problems: long latent phase, long active phase, and arrest of active phase. So in a long latent phase, we have this kind of slow cervical progression to 6 centimeters, and the timing here is very important. So like we said, it's 20 hours for nulliparous and 14 hours for multiparous. And what you want to do is start off with supportive measures: hydration, analgesia, rest. You can throw on some oxytocin after that, and then if that's still not helping out, you can consider amniotomy, cervical ripening with something like a prostaglandin to help the mother along. In active phase, so after we've passed 6 centimeters, then we start slowing down. Let's say we're dilating less than a centimeter per hour or a centimeter per 2 hours. We're starting to have problems, because now we're almost at the second stage of labor where the baby's coming out, but we're slowing down instead of ramping up. And in here, you can definitely consider augmentation with oxytocin to increase contraction strength, amniotomy if it hasn't already happened, and cesarean if both of those don't work. Now, there's a difference between prolonged active and arrested active. If you're in arrested, you don't do any of that oxytocin, amniotomy stuff. You just go straight to cesarean. Okay, so cesarean is for arrested active phase, and really what happens is, after active phase, the membranes have ruptured. There's no cervical change, right? So we haven't had 1 centimeter of dilation in 2 hours or more, and nothing really happens in 4 hours for with adequate contractions, or 6 hours with inadequate contractions. So the arrested active phase, 4 and 6 hours are the contraction cutoffs for adequate and inadequate, and you have this 6 centimeter dilated ruptured membranes, no change in status. You're going to jump straight to cesarean. Okay, and then second stage of labor. So there's problems with the second stage as well. The fetus is about to come out. You have arrested descent. What do you do? Right, so how long do you give for this second stage? Well, you can give 2 hours for nulliparous or 1 hour for multiparous. That's a pretty long time for the second stage, right? So you add an hour for epidurals as well, remember that. And you can definitely augment with oxytocin. If the crown is visible, you can try forceps or vacuum delivery. And if the fetal head is not even engaged with the pelvis, you can definitely consider cesarean. Okay, and then prolonged third stage, so the placenta isn't coming out after 30 minutes. You can consider inadequate contractions as one of the causes, and then do manual removal or hysterectomy if that fails. Okay, so we've gone through the stages of labor, what to do if there's an arrest, the important time variables for those. Let's talk about rupture of membranes. So I mentioned PROM and PPROM. So PROM is premature rupture of membranes, and PPROM is preterm premature rupture of membranes. Okay, so what do each of those mean? So PROM is rupture of membranes that occur before the onset of labor. So before our uterine contractions start happening, before cervix starts dilating, we have rupture of membranes, which is not good because you have all of these risks that come with that. The main one is ascending infection. Okay, so ascending infection complications can also be like cord prolapse, placental abruption, chorioamnionitis, which is from our infection, right? So the fetus can get distressed, have sepsis, get a whole host of problems, pulmonary hypertension, endometritis, everything under the sun with infection is testable here, okay? So definitely watch out for PROM. It happens in about 5 to 10% of deliveries, and if they're at term, you know, then you can go ahead and just induce them, and we'll talk about what to do if they're still waiting. So if they're still waiting, right, you're in a PPROM situation. You're before 37 weeks, you're premature PROM, right? Premature before 37 weeks, rupture of membranes, PPROM. Okay, so in this case, you have the same risk factors for ascending infection, cord prolapse, all of that stuff, and you have to manage these patients in a couple of different ways depending on what week they're at. Okay, but before I actually start on that, there's one more I want to mention, which is prolonged rupture of membranes. And the time here to remember for prolonged is rupture of membranes that happens 18 hours before the onset, 18 hours plus before the onset of contractions, okay, in preterm pregnancies. So definitely want to remember that 18 hours, and definitely want to remember that this occurs in preterm pregnancies. So prolonged ROM, PROM. Okay, so we have PROM, PPROM, and PROM. And they all have different things you need to worry about. But how do we manage rupture of membranes before labor, right? So if the patient is unstable in any way, you want to just go ahead straight to delivery, no questions asked. That's it, right? So unstable mother, fetal signs of distress, you're doing delivery at that point. So if we're greater than 37 weeks, right, we're at term, you can go ahead and induce. If we're at about 34 to 36 weeks, we can also induce. Induction is pretty reasonable, and you know, you can do antenatal corticosteroids to help develop the lungs, and if there's evidence of chorioamnionitis, you definitely want to just go ahead and, you know, as I said, unstable, go ahead and deliver. Cesarean. Gestational age 24 to 33 weeks. For these patients, it's difficult because we can't go ahead and deliver the baby instantly or induce delivery because it's really early, right? So in these patients, we want to start prophylactic antibiotics, antenatal steroids, betamethasone, dexamethasone, your choice. Tocolytics, so we want to kind of delay the birth for at least 48 hours to let the steroids kick in. And magnesium. Magnesium is a very important one because it helps prevent complications with the fetus and also the mother getting things like preeclampsia. So steroids, antibiotics, tocolytics, magnesium. Tocolytics are things like calcium channel blockers and NSAIDs like indomethacin. Okay. All right. So if it's less than 24 weeks, really the 24 weeks is kind of the cutoff for viability. So you're kind of in a terrible situation there. You do expectant management, and that's it. The child is not going to be viable, right? All right. So I think we've covered PROM, PPROM, PROM. What to do based on the weeks. That's it's important there. Okay. Next, I want to talk about what should we talk about? Oh, a really good mnemonic to remember for the exam is Veal Chop for the fetal heart monitoring. So Veal and Chop, if you line them up beside each other, VEAL and CHOP, they'll describe how you interpret the fetal heart rate tracer. Okay, so V stands for variable deceleration, E is early, A is acceleration, and L is late. And then beside that, you line up CHOP, which is cord compression, head compression, OK, and placental insufficiency. So variable means cord compression, early decel means head compression, accelerations are fine and are okay, right? And then late decelerations are placental insufficiency. So early is not a big deal if you're in labor, right? Accelerations are okay. Variable, you gotta be hesitant. And late are not great because placental insufficiency, right? Okay. That's a mnemonic that I think will definitely score us a few points on the exam. Cervical insufficiency. Okay, so let's talk about the cervix, the cerclage. Cerclage is a favorite question of these test writers. It's essentially a suture that's put in the cervix to help people with cervical insufficiency. Now, what does that mean? Let's say you do an ultrasound of the cervix and it's less than 25 millimeters or 2.5 centimeters at before 24 weeks. Then you have a high likelihood of having the cervix dilate inappropriately and then losing the pregnancy. So to prevent this loss, cerclage is done, suture is placed, and after that, bed rest, don't exercise, don't do anything crazy because you don't want the fetus to kind of slip through that cervix and cause any problems, rupture membranes by accident, anything like that, right? You also want to monitor these people with ultrasound. 16 to 24 weeks is kind of the high risk zone for them. And you can only do cerclage in singleton pregnancies. For twins, it's not really advised because at that point the uterus is just too big. The cerclage isn't going to do much anyway. And actually, the twin pregnancies, they push up against each other, so the chance of them pushing down into the cervix is a little bit less. So remember, it's for singleton pregnancies. It's for short cervical length at less than 24 weeks. You can also do progesterone supplementation if that's not working for you. So that's an alternative if cerclage cannot be done. All right. And that's that, I think. Another topic that I think we should cover is acne, mainly the treatment of acne, because it pops up on every single exam. I've seen it everywhere, so it can get confusing. They definitely try to trick you with this topic, even though it should be straightforward. So acne treatments, you want to start off with topical. So topical, then oral, always in every case, right? So topical benzoyl peroxide is number one first line. That's your go-to acne treatment. Then you add topical retinoids and topical antibiotics. So if you had to pick an order, you'd say, okay, I have a topical benzoyl peroxide, topical antibiotic is next, or topical retinoid. Take your pick, right? Then we add oral. Then it's oral antibiotics. These are going to be your doxycyclines, your tetracycline class. So topical is benzoyl peroxide first, then retinoids and antibiotics second, then oral antibiotics, then isotretinoin oral. That's your absolutely last line, okay? So that's kind of the order you should approach this in. Topical is first, benzoyl peroxide is first, and then the other two are second. That's retinoids, antibiotics. Then the third is oral antibiotics. Then the fourth is isotretinoin. Don't jump steps because they'll try to get you to pick oral isotretinoin when you shouldn't. And always remember, because it's a vitamin A analog, you got to do a pregnancy test and liver function tests throughout the course of the treatment, okay? All right, next let's talk about HPV. Okay, HPV is a good topic because it causes warts, and they'll try to throw you off with the different numbers of HPV. Anything that has numbers is easy for test writers to throw in there because it's pure memory. Either you remember what number that is or you don't. So it's either easy points or tough points, depending on if you study them. So HPV. The harmless types are 1, 2, 4, 6, and 11. And the risky types are 16, 18, 31, and 33. So let's talk about what each virus type causes and how to treat the associated sequelae. Okay, so 6 and 11, that's your anogenital warts, your condyloma acuminata. So don't confuse that with condyloma lata from syphilis. This is acuminata from HPV. And so these are anogenital warts. They're tumors essentially of the non-genital mucosa, and they can also happen in the oral cavity, the esophagus, the eye, in some more immunocompromised people, right? And then 16, 18, 31, and 33, these are the ones that cause cancer. They're responsible for 70% of cervical cancers. That's why we screen for them with PAP, looking for those coilocytes, remember? Those are all HPV infected cells. They also can cause risks for oropharyngeal, squamous cancers, especially of the penis. Remember, that's our bonoid papillosis. And 1, 2, 4 are the skin warts on the hands and feet. So those are pretty benign. You don't really got to worry about them. They're verruca vulgaris, vulgar. They're not good to look at, right? They're vulgar warts, hands and feet. So I can remember that by 1, 2, 3, 4. Who's that crawling out the door? It's HPV, okay? And when you crawl, you're on your hands and feet, sort of. So that's how I remember that. And 16 and 18 is the, if you remember the sketch, it's the 16-year-old and the 18-year-old from Sketchy that are at the date. And remember, E6 and E7 are the proteins they affect. E6 is the P53 inhibitor, and then E7 is the RB, retinoblastoma gene inhibitor. So you've inhibited your tumor suppressors, and now you have tumors forming. So condyloma acuminata from 6 and 11, very common in immunodeficient people, as well as, younger children. And you get these cauliflower-like warts. These can progress to local cancers if you're immunodeficient. So you always want to treat them with, you can treat them with local excision. You can treat them with immune modifiers like interferon and imiquimod. Imiquimod is a good one because you don't see it that often, so it's great test fodder. It's an immune modifier used in HPV wart treatment. Imiquimod, okay. Cryotherapy is also a great one. CO2, nitrogen gas can be used to super freeze these warts off. And then flat, these condylomas come in kind of two different flavors. These cauliflower ones and flat ones. So the cauliflower ones are 6 and 11, and the flat ones are 3 and 10. Really, if you had to decide between the two, right, the more common to be cancerous is actually the flat one, so that's 3 and 10. 6 and 11 are more commonly to be benign. So if you look at a lesion and it looks flatter, it's more dangerous, and if it looks more cauliflowery, then it's more likely to be benign. But I would definitely treat both, okay? But just remember, the flat ones are more dangerous. Okay, then I think we've covered a pretty good amount of HPV common knowledge, right? So we've covered the dangerous ones, we've covered the ones that cause verruca. The treatment is excision or immune modulation. Remember, imiquimod is an important one there, right? Okay, so moving on. We can talk about a GI condition. I think we can move on to more GI stuff. I think colonic polyps, FAP, microscopic colitis are great test topics. But we'll cover that in the next podcast. We can do a deep dive into more GI related topics. I really wanted to focus on more female health and STD related topics in this one. So I hope we've gone through some good high yield topics for OBGYN and for reproductive health. Okay, so remember to tune in into podcast part 12 for those GI topics coming up next.